This is a map showing the organization of the endocrine system. You can distinguish different levels in a kind of pyramid. On top we have the central nervous system with the hypothalamus that connects with the pituitary gland in what is known as the hypothalamus-pituitary axis. The pituitary is the first target of hypothalamic hormones. This gland is made of an anterior part or adenohypophysis and a posterior part or neurohypophysis. They produce several hormones that usually target other endocrine glands in the body. The hormones that these final glands release will target different body tissues where they produce an effect. This image shows the anatomical structure and relationship between the hypothalamus and the anterior and posterior pituitary. You can also see the hormones each part of the pituitary gland produces. So, at the top we have the hypothalamus, which is part of the central nervous system where emotion, pain, body temperature and other inputs are communicated, and which controls the release of the pituitary hormones. The hypothalamus produces corticotropin-releasing hormone, thyrotrophin-releasing hormone, growth hormone-releasing hormone, and gonadotropin-releasing hormone. The hormones releasing actions of the hypothalamus need to be controlled, and this is done by negative feedback from hormones and by a variety of neural inputs. These neural inputs are produced through neurotransmitters like acetylcholine, dopamine, norepinephrine, serotonin, gamma-aminobutyric acid, and opioids. Interleukins also modulate the hypothalamus. So, the hypothalamus is basically a bridge that canalizes multiple signals to the endocrine system. One step down we have the pituitary gland. Here you have a list of the hormones produced by the anterior pituitary. We will rapidly review their actions in a minute. As you see in this map, the hormones produced by the final endocrine gland usually have a negative feedback on the hypothalamus-pituitary axis that stops the secretion of the initial hormone that controls the cascade. In other cases, like with insulin, the control is in the hands of a non-hormonal substance like glucose. This fine control maintains the body in homeostatic balance. Given the connection of the endocrine system with the central nervous system, many other factors influence the release of hormones, like stress, external temperature or nutritional state. As usual, we will review the most common conditions in relation with the endocrine system. We will start with hypopituitarism and then the most common disorders of adrenal cortical function.
Hypopituitarism is the underproduction of hormones released by the pituitary gland, and the symptoms depend on which hormones are actually undersecreted. If all of the pituitary hormones are affected, it's called panhypopituitarism. The pituitary is a pea-sized gland, hanging by a stalk, from the base of the brain. It sits just behind the eyes near the optic chiasm, and the gland rests in a very small depression of the skull known as the sella turcica. The pituitary gland produces and secretes hormones when it receives signals from the hypothalamus. Together, they form the hypothalamic pituitary axis, which regulates the release of all the major endocrine hormones. The anterior pituitary contains a few different types of cells, each of which secretes a different hormone. The largest group of cells are the somatotropes, which secrete growth hormone, which goes on to promote tissue and organ growth. The second largest cell group are the corticotrophs, which secrete adrenocorticotropic hormone, or ACTH, which stimulates the adrenal glands to secrete cortisol, a hormone that controls the stress response, blood pressure, and metabolic regulation. A smaller cell group are the lactotrophs, which secrete prolactin. Prolactin stimulates breast milk production, and also inhibits ovulation and spermatogenesis. There are also thyrotrophs, which are cells that secrete thyroid-stimulating hormone, or TSH, that stimulate the thyroid gland. And finally, there are the gonadotrophs, which secrete two gonadotropic hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, both of which go on to stimulate the ovaries or testes. The posterior pituitary releases the antidiuretic hormone, or ADH, which is made by the hypothalamus. ADH acts on the kidneys to decrease the amount of water lost in the urine. The posterior pituitary also produces oxytocin, which is responsible for uterine contractions during labor and milk letdown during breastfeeding. Hypopituitarism can be the result of compression, tissue ischemia or infarction, and iatrogenic, which means medically induced injuries. Let's start with compression. Because the pituitary is located in a very confined space of the sella turcica, it is very sensitive to changes in that space. Even the slightest bit of compression can interfere with the pituitary's hormone production. In adults, the most common cause of compression is a pituitary tumor or adenoma, and in children, the tumor is usually a craniopharyngioma. Craniopharyngiomas are pituitary tumors that develop from the cells of Rathke's pouch, a structure that normally develops into the anterior pituitary gland during fetal development. In addition to solid tissue compressing the pituitary gland, liquid, like cerebrospinal fluid, can also have the same effect. In empty sella syndrome, for example, the sella becomes filled with cerebrospinal fluid and it can make the pituitary shrink or flatten and ultimately become non-functional. Hypopituitarism can also be due to pituitary apoplexy, as a consequence of an hemorrhage, or an infarction of the vessels to the gland. The more common way is a hemorrhage. The hemorrhage is usually caused by a pituitary adenoma. Larger tumors demand more blood, and increased blood flow means increased pressure in the vessels, eventually causing them to rupture and bleed. A less common cause of hypopituitarism due to pituitary apoplexy is infarction of the pituitary gland. An example would be Sheehan's syndrome, which is commonly associated with pregnant women. During pregnancy, there's an increased demand for blood by the pituitary cells, and coupled with excessive blood loss during childbirth, it leaves pituitary cells without adequate blood flow and they start to die. If the blood flow isn't restored soon enough, more and more tissue dies, and over time, the pituitary gland shrinks and can't effectively secrete hormones. Finally, there are iatrogenic causes of hypopituitarism, like when there's unintentional damage to the pituitary gland during radiation therapy or neurosurgery. Symptoms of hypopituitarism can vary greatly depending on which hormones become depleted. In general, luteinizing hormone, follicle-stimulating hormone, and growth hormone are lost before thyroid-stimulating hormone and adrenocorticotropic hormone. So let's go through these in order. Hyposecretion of follicle-stimulating and luteinizing hormone can cause problems for men and women. Women may experience oligomenorrhea, which is a decrease in their menstrual bleeding, or amenorrhea, which is a complete absence of menstrual bleeding, and possible infertility. Men may experience loss of pubic hair and a reduction in muscle mass. Both men and women commonly complain of a diminished libido. Loss of gonadotropins is also seen in Sheehan's syndrome, resulting in similar symptoms like absent menstruation, but the loss of prolactin also causes problems with postpartum lactation. Moving on, a lack of adrenocorticotropic hormone causes adrenal insufficiency, or a lack of cortisol production by the adrenal glands, and that leads to weight loss, delayed puberty, and low blood sugar and sodium levels. Growth hormone deficiency results in a failure to grow in children, delayed puberty in adolescents, and lean body mass, and low bone density in adults. Hypopituitarism can also cause hypothyroidism due to the diminished production of thyroid-stimulating hormone, with classic symptoms such as weight gain, constipation, hair loss, and low blood pressure. Finally, in addition to all the endocrine abnormalities seen in hypopituitarism, if there's a tumor or fluid buildup, it can cause local symptoms like increased intracranial pressure and headaches. The pituitary gland is also close to the optic chiasm, which is where the optic nerves cross. So any extra pressure in the area will press on these nerves and lead to visual field defects like bitemporal hemianopsia, where the person suffers partial blindness in the lateral fields of both eyes. Diagnosis of hypopituitarism is usually done by first assessing baseline levels of hormones in the morning, which accurately measure all the pituitary hormones except for growth hormone and adrenocorticotropic hormone, because those hormones levels are more variable throughout the day. Next, it is helpful to see how hormone levels change in response to a substance that should stimulate hormone release. For example, administering insulin should cause a drop in blood sugar, which in turn stimulates the release of growth hormone and adrenocorticotropic hormone from the anterior pituitary. If these hormone levels remain low, despite the stimulatory effects of insulin, it may indicate hypopituitarism. Finally, MRI scans can help to look for possible causes of hypopituitarism, like tumors or hemorrhage. Treatment of hypopituitarism are based on correcting the underlying cause. In the case of an adenoma, surgery can be performed to remove the tumor. Hormone replacement therapy might be needed if the pituitary damage is severe.